Yeah, so we can start. So nice to meet you. I come from Jerusalem, from a university center where we deal with a lot of births. And I just want to emphasize here the advantage of being in touch with other departments. We all love multimodal imaging, but mostly deal with specific ophthalmology conditions. Now we will try to expand our horizons to other things. Many advices are requested from obstetrics to ophthalmology department, particularly when you deal with complicated pregnancy. I mean, twin and more, and where you have a higher prevalence of eclampsia, pre-eclampsia, and so on. We all witnessed during the last decade a huge development in non-invasive ophthalmology diagnostic capacities, and we should look at pregnant people, pregnant women, as a population at risk from certain points. So a lot of has been published, or not so much, but enough to have some idea, but there is not so much information about what to do with OCT and geography, for instance, and pregnancy. So I will try to address those topics now. First of all, we have to be aware of some restrictions with pregnant women. We cannot use fluorescent geography as we wish. We all are really keen to perform all kind of wide field geographies, particularly when we want to deal with diabetic patients. But here we have to take care because of heterogeneity concern associated with the use of this technology. We know that the fluorescent crosses the placenta barrier, and which is the fetus where it's very when we will deal with anti-VEGF treatment, it's also a big concern because their VEGF is very active in babies in the womb. So despite the fact that there are today, to our knowledge, there have not been any case report of birth anomalies or complications. It's if we can perform other imaging modalities, so it would be better. We all know that we have OCT angiography, and we can use it really safely in pregnant patients. As I previously told you, VEGF is very important in the development of human fetus, and we shouldn't use it, or if we have to use it, it should be do it with the greatest care. So with regard to treatment, we have to speak of alternative laser treatments and steroids and so on. So what are the problems? Now let's leave the technology, but what are the clinical problems of pregnant women in the retina? So the most common problem is diabetic retinopathy. And when we speak of diabetic retinopathy, we deal with people being diabetic before pregnancy, not for gestational pregnancy diabetes. But out of diabetes, you have other conditions such as pre-eclampsia and eclampsia, which were primarily the eye, and rare things such as disseminated intravascular coagulopathy, amniotic fluid embolism, but the eye generally is the smallest issues, because here there is a concern that the woman can lose her life in such conditions. Another thing, not so uncommon in pregnancy is central serous retinopathy, usually in the final trimester, and one hypothesis is that the result of increased catecholamines during pregnancy. We also see more artery and vein occlusions, whitehead syndromes, and idiopathic or not so idiopathic retinal neovascularization due to increased activity of angiogenic factors too. What with regard to diabetic retinopathy, so it's very, very common when you try to screen pregnant people for diabetic retinopathy, so you'll find that till 60% of women entering pregnancy with type 1 diabetes and till 30% of type 2 diabetes have some kind of diabetic retinopathy. And for sure, people with type 1 diabetic retinopathy, with type 1 diabetes should be seen as a very high risk population. On the other hand, when a woman presents diabetes for the first time during pregnancy, so it's very, very rare. Only case reports that she will develop proliferative diabetic retinopathy. So I don't know how it works in India, but in Israel usually, for most ethnic groups, you don't have a very, very fast progression during the life. You have to wait 1 decade or 2 decades from diagnosis of diabetes till you see proliferative diabetic retinopathy. In pregnancy, it's another thing. So how can imaging help? So we all love multimodal imaging and put a lot of slides with all kinds of fluorescent geography, but here we should remind that we are, first of all, clinical practitioners, and we should use our lenses and just look what's happening in the retina, and for sure we can also perform wide field pictures without injecting any dye. Just to remember that this modality also exists in Optos and other wide field capturing systems, and for OCT and angiography can help us a lot. So just to remind, gestational diabetes, you do not specific eye examination with pregnancy, but people entering pregnancy with already diagnosed diabetes should be really pictured and regularly seen. What do we find in pre-eclampsia? Just leave diabetes. In pre-eclampsia, you have all kinds of things that we should check clinically. Hypertensive retinopathy, occlusions, hypertensive choroidopathy, more difficult to catch, but you can see the alginic spots, and you can have some serous retinal detachments. The most common ocular finding in preeclampsia is severe arteriolar spasms, something that you should discover with your eye, not without any other technology. But if already we use technology, so in eclampsia, you can see all kinds of things. That's an example of swab source, OCT angiography, and unfast pictures there. And I also put some retinal thickness mapping just to show that it's not only the artifact related to the presence of intraretinal fluids. What you see is huge changes in unfast, and when you specifically look at the vasculature, you see changes. Some kind of fast enlargement, and the overall vascular pattern has changed. What's most worrying that when the patient clinically recovers and when you don't see any fluids with structural OCT, you still see some changes, some vascular signs. And that's a composite image just to emphasize the duplexus non-homogeneity, and you can see that peripherally you have some important changes there. So just to conclude with this presentation and to leave some room for questions, we should have a definitely loud threshold for referral and ophthalmologic check as more accurate diagnostic tools emerging, but we should, as clinicians, when a woman is referred, a pregnant woman, for any ocular complaint, just first of all, we rely on our clinical and common senses. OCT angiography will likely change our understanding of pregnancy-induced retinal vascular changes in normal and complicated pregnancy. And we are currently performing some research in the hospital where I work, at Sharet Zedek Hospital in Jerusalem, comparing a group of complicated, namely pre-eclamptic and eclamptic pregnant women with uncomplicated pregnancy and non-pregnant. For the former results we see, there are some vascular changes. For sure, the most difficult things when you do research with OCT angiography is just to quantify the changes. But morphologically speaking, when you try to compare the texture of the vascular tissue of the choroid or even of the outer retinal plexus, you do see some changes between those groups. So it may become one of the biomarkers obstetricians will use in the future just to detect what specific group of women are at risk of having all the eclampsia complications. Thank you so much for your patience and attention.
Thank you, sir. So I would just like to ask you, since you have done so many OCT angiographies in pre-eclampsia patients, did you find a large majority of them having vascular changes or just a minority?
We do. The main problem is the artifact related to fluids. When you deal with patients who are symptomatic, so usually they complain of some metamorphopsia or some blur related to the presence of fluid. So when you try to not to take into consideration the intraretinal fluids, you do see some changes. It's very hard to characterize and to quantify that, but when you compare, when you take two images and you ask yourself which woman has some complications, you point the right image, and we are trying just to translate it now statistically.
So maybe if the patient is just symptomatic and comes to you early, then you might be able to predict by the imaging whether that
might be a good idea, just to put OCT angiography if we find some difference, to put it in the regular follow-up of those patients.
Thank you. Any other